Welcome to the pIBD Digest. We are here to talk about the nuts and bolts of pediatric inflammatory bowel disease that includes Crohn's and colitis, with lively discussions and expert insights.
Myself, Dr. Chris Bakewell, and my colleague, Dr. Tracy Coelho, will be your co-hosts on this journey. In each episode, we speak with an expert guest to better understand pediatric inflammatory bowel disease, support families, and keep healthcare providers informed about the latest developments. Just a reminder, the opinions shared here are those of our guests and hosts and are therefore for educational purposes only. This is not a substitute for medical advice.
Welcome back to the podcast. Usually we like to kick things off with a bit of chit-chat, form up banter, and ease our way in. Maybe tease our guest a little.
Right, but today we're shaking things up with what we're calling the IBD Masterclass. And instead of having one guest, we've gathered a whole panel of experts. And this particular masterclass, we'll be discussing what may be the new frontier of IBD therapy, that is JAK-inhibitors.
Yes, and each of our guests is tackling a different piece of the puzzle. So by the end, you'll get the full picture. Together, they'll walk us through the many sides of the JAK inhibitor story in pediatric IBD.
So listeners, today is about going back to medical school and learning an important topic really in depth. It's a real deep dive, but do stick with us because there's going to be some valuable pearls along the way.
Okay, let's bring in our star lineup of guests and dive straight into the world of JAK inhibitors. Dear friends, as we drift into the fine print of today's topic, what some might lovingly call a JAK inhibitor nerd camp. Rest assured, it's not nearly geeky enough to give you a ear cramp. And I promise we will certainly not be scrambling for the non-nerdy exit ramp. So our first guest this evening is Professor Tony Williams. So Tony is Professor of Translational Medicine and Honorary Consultant in Clinical Immunology and Allergy at the University of Southampton. As the Director of the WISH Lab, Wessex Immunology Sciences Hub, he's at the cutting edge of immunology and allergy diagnostics. His expertise spans everything from recurrent infections and immunodeficiency to immunotherapy and novel diagnostic tools. He's also been heavily involved in work with Genomics England, helping to shape how genomics can be applied to patient care. And on a personal note, Tony was actually my supervisor for the immunology arm of my PhD a few years ago. So there's a touch of reverence here, though hopefully Tony won't be marking me on today's performance. So Tony, welcome to the podcast.
Many thanks. Thanks for having me, Tracy.
So Tony, usually on this podcast, you would see two faces, mine and my co-host Chris Bakewell, on separate screens. But today my co-host seems to have either dozed off or gone into an overdrive prepping for this episode. So you will just have to make do with one face, which, come to think of it, ties in quite nicely with today's topic, Janus kinases, the two-faced Roman god. So Tony, as we kick off a masterclass on JAK inhibitors, I have 3 rapid-fire questions for you. Could you remind our listeners what are Janus kinases and how did that name come about?
Yes, so the JAK inhibitors, the Janus-associated kinases, are a group of molecules that were first identified in the very late 1980s, early 1990s. And they were identified when scientists were looking to better understand how signals from outside cells created signals inside cells, and then various functions would follow from those cells. And what they found that inside the cells, there were molecules that were able to sense the signal from outside the cell with one head of the molecule, and with another head of the molecule be able to transmit that signal inside the cell. And therefore the name Janus, aptly described from the Roman god of duality, beginnings and endings, the ability to sense a signal and then act upon it through two very similar parts within the same molecule. And that the kinase bit then describes the activity of the molecule. So once that two-headed molecule identifies and transmits signal, the kinase describes how a particular chemical group is added to the other molecules then that the JAK begins to interact with. And from there, a cascade of reactions will follow, leading to important changes inside of the cells.
That's an excellent explanation. I know you have touched on this, but what's the specific role of Janus kinases in the immune system?
Yeah, so the JAK-associated family members include 4 family members: JAK1, JAK2, JAK3, and one that might have been called JAK4, but it was called TYK2, but it does the same job as the other kinases. And some of the kinases, such as JAK1 and JAK2, are present in all cells, and then JAK3 is only present in cells that are derived from the bone marrow, so cells such as the immune cells that I deal with in clinical practice. And the cells then that have the JAK3, for example, in immunity, they are able to transmit signals that allow the immune system to be both switched on and to accelerate. And therefore one has to be careful with the JAK kinases, because if they don't work very well, it's like having a brake on the immune system and you might become susceptible to infection. If you have the accelerated pressed down too hard, the chemicals secreted by the immune cells may set up excessive inflammation and lead to problems therein. And then again, once you try to pharmacologically interfere with the JAKs, you just have to get the dose right so that it's not too hot and it's not too cold, depending on what you're trying to achieve.
Perfect. So my third and last question for you, Tony. Why do you think JAK inhibitors can be useful in autoimmune conditions, including IBD?
Yeah, so the history of JAK inhibitors in autoimmune conditions, so those conditions where the body's immune system turns on itself rather than identifying infections from the outside world, goes back to rheumatoid arthritis. So that was the first autoimmune condition where JAK inhibitors in a clinical trial showed that there was significant improvement in that condition back in 2012. And the first licensing of the agents was provided to rheumatologists to more quickly control resistant rheumatoid arthritis, and do so with an oral medication as opposed to some of the injections that have shown themselves to be powerful allies to those trying to treat individuals with rheumatoid arthritis. And then over the years, with increasing confidence of how they work and the side effects they may have, they extended their use to other autoimmune conditions, those of the skin, such as psoriasis, and then over the last 6 or 7 years into inflammatory bowel disease, initially with ulcerative colitis and then more recently with Crohn's disease. And they have an ability to cross autoimmune conditions like this, because many of these conditions, although they may affect different parts of our bodies and lead to different symptoms, the underlying process that leads to that disruption is similar, and therefore a medicine such as the JAK inhibitors can be utilized in these different settings carefully to ensure that the immune system is dampened, and that dampening switches off the inflammation then that we know is so troublesome in conditions like inflammatory bowel disorders.
Tony, that was a brilliant glimpse into the double life of Janus kinases. Thank you for joining us on this two-faced adventure. Thank you.
My pleasure.
Take care then. Bye-bye.
Thank you. Bye.
Now that our listeners have had a quick peek at the Janus kinases, it's time to welcome our next panel of guests. And yes, I know some of you might already be thinking about the two-faced people you know in your lives and wondering which face to slap first. Hey Chris, you're back.
I am. Have I missed much?
No, not to worry. We can always catch up. So next up on the podcast, we have 3 IBD pharmacists from London, Liverpool and Southampton. So we have Courtney Preston, Helen Doble and Melody Chan in that order. Welcome, Courtney, Helen, and Melody.
Hello. Thanks for having us.
Hi.
Hi.
Okay, welcome to the pIBD Digest, and thank you for joining us. All experts, all ladies, and I hope you don't mind me saying this. Your presence, your names, it almost sounds like the start of a new girl band on the IBD pharma charts. So we'll kick things off in London, head off to Liverpool, and then, last but definitely not the least, Southampton. So let's go round the map. Now, before we do that, could you please give our listeners a quick intro?
Hi, so I'm Courtney. I work at Chelsea and Westminster Hospital here in London. So we're a tertiary centre for paediatric gastroenterology, and we've got quite a big paediatric IBD cohort here.
Hi, I'm Helen. I'm a gastropharmacist at Alderhay. I've been doing that for around 10 years. I'm also an advanced clinical practitioner in IBD.
Hello, my name is Melody. I'm a specialist pharmacist working at Southampton Children's Hospital. I gradually moved into working with the paediatric gastroenterology team in 2020 and haven't left because they provide biscuits at their weekly meeting.
And also you found a husband.
Not within the department.
Since you are all experts in your field, we have lined up a set of questions for each of you. No buzzers. No one is getting voted off the podcast at the end. It's purely for our learning and, of course, for our listeners. Okay, let's start off with our London JAK correspondent. Now, JAK inhibitors are really huge in the IBD world right now. But ironically, why are we so sizist at the moment by calling them small molecules?
So we're quite used to biologics or MABs, however you want to call them, in pIBD. And these are big proteins. They're coiled into a very specific shape, different regions or protein chains. For example, you couldn't draw the chemical structure of infliximab out carbon by carbon. Or perhaps you could, but it would take a very long time and probably be quite unpleasant. I think the molar mass or molecular weight would be in the hundreds of thousands, probably about 150,000, I think it works out to be. Whereas JAK inhibitors came along, for example, upadacitinib, and you can draw this out. You can draw out the exact chemical structure. It may maybe take you a minute or a few. It depends how good you are at drawing hexagons. And the molar mass is about 380. So much, much smaller compared to something that's about 150,000. So these are much more like traditional drug compounds with a relatively simple chemical formula. They're not big proteins like we're used to with biologics.
As you mentioned, we can actually draw the small molecules unlike the biologics. Although if I tried sketching one, it would probably end up looking like abstract art rather than chemistry, more like a toddler's doodle. So, although you may have explained it already, pharmacologically, what's the difference between the small guys and the burly biologics?
A little bit. But yeah, so the size kind of does affect the way that they work as well. So, like I said, biologics are a very complex protein. So they're too big to enter into cells. So they have to work extracellularly. They bind to cytokines or cell surface proteins, and they block the action of that particular cytokine or immune cell, which is, of course, helpful when certain parts of the immune system are overactive. JAK inhibitors, on the other hand, are small enough to enter into cells, so they work intracellularly and directly on Janus kinase enzymes. And this, in turn, affects cytokine signaling downstream. Because JAK inhibitors are small and relatively simple chemical compounds, they can be taken enterally, so by mouth or by potentially by feeding tubes, whereas biologics are proteins, and they would just be broken down if they were taken that way. So they need to be given parenterally, so usually IV or subcutaneously. They have quite different side effect profiles too. relation to kind of their size and how they then interact with cells. But I believe one of my colleagues will come onto that a little bit later.
Thank you. So before the advent of biologics, we had small molecules in place anyway, and they were widely used for IBD. I'm talking about thiopurines. Of course, a lot of people don't like to use it. Now, and then we have these JAK inhibitors, which are small molecules again. Could you tell us a few reasons why small molecules may be better than biologics in some ways?
Yeah, I'd say the benefits of JAK inhibitors depend a lot on the patient. There are certainly some perks that would be really beneficial to some certain types of patients. For example, patients and families that really struggle to get to the hospital really frequently for infusions, especially if they're on kind of an escalated regime of something and they're coming in every 4 weeks, for example. An oral medication that they can take at home alleviates that issue. Similarly, you might have patients who are missing doses of biologics for whatever reason, and they can, of course, develop anti-drug antibodies and lose response to the treatment that they're receiving. Whereas because JAK inhibitors are simple chemicals, they're not noticed by the body as kind of foreign proteins. So we call them non-immunogenic. Of course, patients who are regularly having their infusions can still also have issues with immunogenicity, but this isn't something we have to worry about with JAK inhibitors. They may also be an option for kind of patients who've had persistent issues with cannulation, or thinking about lines and things for biologics, or patients who have had severe hypersensitivity reactions to biologics. They can also have a quicker onset of action than some of the biologics like vedolizumab, which can take several weeks to reach full effect. So they might have a place in therapy in terms of inducing remission.
Excellent. Coming back to biologics, so we had originator biologics and then came biosimilars, so which were much cheaper than the originator biologic molecules, drugs, I mean. Now, the concept of biosimilars may not be relevant to small molecules compared to biologics. Could you explain that concept to our listeners, please?
Yeah, so as I mentioned, JAK inhibitors are simple molecules. And with that, it means that the manufacturing is much simpler. So these are well-defined molecules that can be completely synthesized in a lab without the need for living cells to be involved at any stage in the process. You kind of just need the recipe, so to speak, of how to make it in a lab, and you should always get an identical molecule. Some compounds might have many, many steps and be very technically difficult to manufacture. I don't want to upset any chemists, but they don't require living cells. So it tends to be a simpler manufacturing process where you always get an identical chemical. And the manufacturers might tinker with the formulation of the drug, so the excipients in the tablet or capsule, or they might develop oral liquid versions, but the active ingredient will always be exactly the same. So when these drugs come off of their patent, we'll most likely get generic versions come through, which brings the price down quite a lot. Biologics are a bit different. They are so complex that you can't just use chemicals in a lab. You have to use living cells and at least part of the manufacturing process. So each biosimilar manufacturer might have slightly different cell lines or manufacturing processes. And this means that the molecules that you get at the end aren't completely identical. They'll be very similar and they'll work in a very, very similar way, and they'll have the same effect, but they won't be identical, which is why they're called biosimilars and not generics. Now, these biosimilars have to be tested and they have to be shown to work in the same way. And sometimes clinical data in real patients might be required to prove that that the biosimilar has the same effect clinically as the originator drug, which isn't something that we have to do for generics. When a generic kind of small molecule, a typical drug comes off patent, you can manufacture a generic without having to prove that it has the same effect.
That's amazing. Thank you, Courtney.
Helen, now over to you. Could you walk us through the different classes of JAK inhibitors? For example, what's the difference between a pan-JAK inhibitor, a selective JAK inhibitor, and I guess more to the point, why does that matter clinically?
So I think we've already heard about how JAKs work, and the drugs, their main ones, the main JAK inhibitors that we've got are JAK1, JAK2, JAK3, and the tyrosine kinase. JAK1 strongly linked to inflammation, JAK2 is for blood cell production, and JAK3 is lymphocyte activity. And then the tyrosine kinase 2 is involved in signaling pathways. So we've got an inhibitor, which was the first to come to the market, which is tofacitinib. And that is described as a pan-JAK inhibitor, but mainly it blocks JAK1 and JAK3 and has some activity on JAK2. Because of this broad activity, it's effective in reducing inflammation, but also carries a risk of more side effects because it's targeting those other bits, such as anemia and lymphopenia. And then we got some lovely new shiny ones, upadacitinib and filgotinib, and they're more selective for JAK1. And why does this matter? Because the JAK1s can target the inflammation more specifically and tends to have fewer side effects, mainly the blood-related ones. That said, the way the JAK works, so the JAK1 pairs with JAK2 and 3, so it's not entirely selective, and there still might be some cytopenias that can occur.
Sure. And of those drugs you've just mentioned, which are the ones that we would more commonly use in paediatric IBD? And do they have a kind of specific flavour for IBD phenotypes?
Yeah. So the upadacitinib is the main one, and that's licensed for Crohn's disease and ulcerative colitis. Whereas the tofacitinib, which is the pan, and the filgotinib are only licensed in ulcerative colitis. In pediatrics, we don't actually have any formal licensing as of yet, so we're using all of these off-label. The tofacitinib, we can prescribe that from 2. The reason why we can do it from 2 is because we've got safety data for rheumatology, whereas with the newer ones, the upadacitinib and the filgotinib, we can only use from 12, and that's under the Medicines for Children framework. Actually, that's not true. We can use from 12, or if they are post-pubescent. So if we've got a 10-year-old that's gone through some Tanner staging, then we could use it in that way. And there are some clinical trials going on at the minute for pediatrics, but we're still waiting for them to come out, or we're just getting into them. So the filgotinib can be used from 8 once those trials have been completed, and the upadacitinib, I think, is from 2. So that would be amazing.
Okay, great. Thank you. Melody, I guess taking a step back, but keeping with the clinical stuff, here in the UK, what happens when a clinician, Tracy or I, or anyone decides to start a treatment with a JAK inhibitor or any biologic medication for that matter? What kind of steps and what's the process involved? Things like blue text, etc.
Yeah. So obviously, there is, JAK inhibitors, biologics. They come with, side effects. So there is often monitoring that will come first. So with biologic treatment, that's often a quantiferon chest X-ray for latent TB. But due to the immunosuppressive effects of kind of JAK inhibitors, we often also screen for hepatitis B and C, varicella zoster, EBV and CMV. In terms of monitoring, there's the usual monitoring for full blood counts, renal and liver profile for biologics. But JAK inhibitors also require lipid profiles because they increase the total cholesterol and triglycerides in some patients. Because of these side effects, we also need to make sure that the patients are appropriately counselled for starting their treatment. So obviously looking for signs for infections, malignancy, thrombotic events, which are kind of side effects that are extrapolated from adult data. But obviously our patients might be on these treatments for a lot longer than some of the adult patients. So it's kind of important to let them know. More importantly, for our patients who are of female childbearing age, we have to remember about contraception advice. I feel like something as pediatricians, we sometimes forget that our patients have a life too outside our clinics. There are obviously funding issues with these JAK inhibitors. As Helen has mentioned, NHS England has imposed the ages where we can and can't use these JAK inhibitors. These kind of can be found on the appropriate blue tech forms, and this should always be completed before we start treatment. Lastly, I think thinking about where your treatment supply comes from is also important. These are specialist medicines. Primary care won't take on the prescribing. A lot of the time, district general hospitals won't keep a supply of them. So often patients are established in tertiary centres via outpatient prescriptions. But thinking long term, actually setting patients up for home care means that their supply can be a bit more constant and reliable.
Thank you, Melody. That was really comprehensive, and I think touches on my next point really well. Historically, licensing for these medications in IBD for children has been really challenging, and we still only have licensing for 2 medications. So, as in 2 biologics, that is infliximab, adalimumab. So we have to, I guess, have a UK-wide policy, right, for how we use these JAK inhibitors. Is there anything, you touched on it, from NHS England to guide their use for commissioners to make sure that the local hospitals, the tertiary centres are happy to, I guess, fund them?
Yeah, so paediatrics itself is regarded as a specialist area in itself. So kind of funding-wise, asking hospitals to budget for medicines in children, where some hospitals might have lots of paediatric patients and some have none, isn't very fair. To combat this and ensure that children have appropriate access and it's kind of fair for all patients, paediatric funding for specialist services comes through NHS England in a central pot. The tricky part, like you said, comes with that a lot of medicines not licensed in children. In fact, one study found that actually 67% of medicines prescribed in children in hospital is unlicensed. So how does NHS England know what medicines to commission? A lot of it does boil down back to what is commissioned in adults within the NHS. It's often decided by NICE. So if a drug has a positive NICE technology appraisal, then often children can have access to the drug through the commissioning medicines for children in specialised service policy. In order to monitor that the hospitals and clinicians are compliant with this medicines for children policy, they utilise a database called BlueTech. This generates a authorization number, so hospitals can use this as part of their billing process. BlueTech mainly checks on the condition that the child has, appropriate monitoring has taken place, treatment escalations, and discussions have been made appropriately with the wider MDT. Is anyone still awake?
Well, I was just thinking what you really need then is a really good IBD pharmacist. You've given the sell. That's good.
Helen, my next question for you. What challenges might arise in adherence, dose adjustments, and its long-term use, particularly in adolescents?
I think the concern with JAKs is because we're not sitting on an MDU unit, and while that's brilliant for the patients, it can be quite concerning for us because we like that control, don't we? That we can see if they didn't attend or if they would be doing like fancy drug monitoring, such as we're doing with anti-TNFs, and we can change that. Whereas all of this is happening in primary care. We're sending the drugs out and we're only getting blood monitoring done maybe every 3 months or so. And with the limits and pressures that we've got on services, we may only be seeing these patients every 6 months or a year. And these tend to be our more difficult cohort. They might have been ploughing through all of these medicines already, and it might be the last one. Then you're factoring in teenagers who are notoriously difficult to get them to take medicines. So there's a lot of trust on both sides in trying to get them to take it and for us to give up that trust. So it is a concern, and we need to have good communication with patients. There is also dose adjustments that need to be considered for renal impairment and for liver impairment. And this can be quite difficult whenever you factor in that it's for ulcerative colitis as well, and you might have a PSC crossover. So it's definitely worth having an MDT review and discussion with that. There's also with teenagers in particular, as Melody also touched on, they're not the same as kids, so we need to consider that they may be on contraceptives, and that increases their risk of DVT. And also that they may be family planning as well, and we're not really good at discussing that. So they might make a decision themselves about stopping the drug because of something that they read. So we need to be like hot with our communication with our teenage cohort.
Okay. So my final question then is for you, Helen, if that's okay. We've heard a lot of good things about JAK inhibitors. In many cases, they may all offer a good alternative to biologics. But how does the cost compare? Because biologics are expensive. Are these new fancy drugs expensive too?
Yeah, so they tend to be relatively the same bracket as the newer biologics like the risankizumabs. The BNF has a list price of around 10,500 a year in around for the upadacitinib and the filgotinib. And that's before any of the discount schemes that we might see in the NHS. This is obviously considerably higher than adalimumab or ustekinumab or infliximab, which are all now under the biosimilar bracket. But there's other considerations that, like we don't need to get a space on MDU, so we've got less nursing costs. We can put this on home care, so there's additional savings there. Sometimes it's a different list price. And also the home care company will deliver it to the patient. We don't need any fancy monitoring with this, so a lot of it can be done by GPs. And then there's the kind of hidden costs for the families, that they don't have to travel to the hospital. The parents aren't losing time off work sitting on an MDU. And the patients aren't missing out on school times either. So although it's coming in at quite expensive, it's similar to other ones, and we've got some nice other costs that we can factor in.
Yeah, so I guess you're saying they're not more expensive, and if in some cases they're clinically superior or certainly similar, then that sounds like a win.
Absolutely, yeah.
So Courtney, back to you. I've got a couple more coming your way. Let's dive into the doses of these medications before anyone eats a dose of coffee.
Yeah, so we're all kind of getting used to dosing for these new JAK inhibitors, and some of them have a little bit more flexibility than others. So if I start with upadacitinib, patients usually start with a slightly higher dose, what we might call an induction dose, up to 45 milligrams, which is taken as one tablet once a day, nice and easy, for usually 8 to 12 weeks. This induction period can be extended if there's been an inadequate response. And then patients tend to drop down to a maintenance, usually 15 or 30 milligrams. Now, there's not much flexibility of the dosing of upadacitinib. Patients have to be able to swallow the whole tablet because it's a prolonged release formulation. So it's usually reserved for patients kind of 12 years and above. Tofacitinib actually comes as a liquid as well as tablet, so there is a bit more flexibility in dosing, which allows us to use it in much younger children if required. Dose is either banded by age, or some centres might use milligram per kilo dosing in smaller patients up to a certain weight, and then generally, depending on the centre, some places might use adult dosing if the patient weighs, say, 30, 40 or even 50 kilos and above. They might just use standard adult dosing. Tofacitinib is taken twice a day. Similarly to upadacitinib, there's a higher induction dose, up to 10 milligrams twice a day, usually for 8 weeks, which can also be extended if needed. followed by a lower maintenance dose, which is usually up to 5 milligrams twice a day. And then finally, filgotinib. This is the one I'm least familiar with. I haven't actually seen this used as of yet, but it could be used in post-pubescent patients. Dosing is once a day, similarly to upadacitinib. The starting dose is 200 milligrams for an induction period of about 10 weeks, which can either be continued as a maintenance dose or can be reduced to 100 milligrams if 100 milligrams is adequate or if the patient has risk factors for serious side effects.
Great, thank you. So I know that we don't use other immunosuppressive medications with JAK inhibitors often, but there might be a time when there's more evidence we might start using other medications. So are there any important drug-to-drug interactions with JAK inhibitors that we as clinicians, pharmacists, and families need to be aware of?
Yeah, so upadacitinib and tofacitinib in particular, you need to be really careful with strong CYP or CYP inhibitors like ketoconazole and strong inducers like rifampicin, because these could really increase or reduce exposure, especially for tofacitinib, which might actually even need dose adjustments if concomitant therapy is absolutely necessary with one of these inhibitors or inducers. Filgotinib isn't CYP dependent, so has far fewer interactions. It is a PGP substrate, so it could affect the levels of other drugs that are PGP substrates and vice versa. But the ones in the manufacturer's interaction studies weren't actually clinically significant enough to warrant any dose adjustments. So in general, filgotinib has fewer interactions to bear in mind. But we also need to think about drugs that might have an additive effect. So anything immunosuppressive could be quite dangerous, but I think a colleague is going to discuss that specifically in a bit more detail. And then also anything with a similar kind of side effect profile. So even things like estrogen-containing contraceptives in adolescent girls, which could lead to an increased clot risk. Children and teenagers are generally low risk for kind of cardiac and thrombotic events. But what we don't want to do is create a perfect storm, please, otherwise rare complications to occur.
Thank you all. That was really like a hop-on, hop-off city tour through London, Liverpool and Southampton. We have learned loads. Sadly, our ticket is about to expire. But before you leave, I have one last question, slightly less medical question, as usual. Now, at the start, I floated the idea of a girl band as a side hustle. So keeping today's theme of JAK inhibitors in mind, if you were to form a pop group, which name would you choose? The Jack Street Girls, Jackson 3, not Jackson 5, or the ABBA-inspired The Inhibitor Takes It All?
Oh, I think we need a countdown clock here, don't we?
Oh, I think I like the Jackson 3.
I suppose I'm a millennial, so I'm going to go Jack Street Girls.
I'm also a millennial, so Jack Street Girls appeals to me.
Great choice. Millennial appeals to me as well. That's wonderful. Thank you so much for joining. So if you do decide to form the girl band, be assured that you will be hired for Busbagan Conference 2027 to be held in Southampton. For now, thank you very much and bye-bye.
Thank you so much. Thank you.
Cheers. Take care.
Bye!
Now looking back at my ticket, it seems I can still squeeze in one more stop, Sheffield. And who better to meet than the Robin Hood of pediatric IBD himself? He has been stealing inflammation from the troublesome immune pathways and giving health back to children's guts. So please welcome our guest from Sheffield, Dr. Akshay Kapoor, to talk about JAK inhibitors in IBD.
Yeah, welcome to the masterclass, Akshay. I don't suppose you'd mind starting by introducing yourself to our listeners, giving them a flavour of who you are and what you're about?
Of course. Thanks, Tracy. Thanks, Chris, for the very, very kind introduction, I must say. As you've already introduced me, Tracy, I work at Sheffield as a consultant in pediatric gastroenterology, but also as lead of the IBD service over there. Just as a background, I've trained in inflammatory bowel disease at the Hospital for Sick Children in Toronto. Was there as an advanced IBD fellow for around 2.5 years. And then I came over to Sheffield and have since then been doing a lot of IBD stuff. I am on as the principal investigator for a lot of the new drug trials that are there in IBD. So they're exciting times, I think.
Thank you for the introduction. Akshay, to begin with, we can present a hypothetical but quite a common clinical scenario. So we have a 15-year-old boy with a 2-year history of extensive ulcerative colitis, presenting with worsening of bloody diarrhea and tummy pain. He remains on oral 5-ASA and azathioprine and very compliant. He previously required steroids on a few occasions over the previous year. He was started on infliximab few months ago with some improvement at the beginning, but developed secondary loss of response despite escalation and therapeutic trough levels. We also considered adalimumab, but he was not well enough for that. So we started him on Vedo, but he had persistent symptoms and elevated fecal calprotectin. Now he is admitted as an inpatient with ongoing acute severe colitis. Now, given the failure of anti-TNF, anti-integrin therapy, ongoing severe disease, and family's strong preference to avoid colectomy, we at our IBD MDT decided in Southampton, why don't we escalate treatment to oral JAK inhibitors as the next line of therapy? So the first question for you, what are the treatment options for this 15-year-old, and are there other treatment choices available for this age group?
Thanks, Tracy. Quite a difficult scenario, but quite a common one. I must admit we see these patients often. So we've got someone who's failed 2 biologics now. I guess from what he told me, he's got steroid-dependent disease as well. So essentially, the therapeutic options, if the family is not keen for surgery, are either we go down the line of the anti-IL-12/23 inhibitor, which is ustekinumab. We've also got the sole anti-IL-23s now, which basically inhibit the P19 subunit, which includes drugs like risankizumab, guselkumab, and mirikizumab. So we've got those line of drugs. They are obviously, they are IV infusions followed by subcutaneous injections. And then we've got these new exciting oral drugs called the JAK-inhibitors, which are slowly making their way up the pediatric IBD drug table. They're obviously not approved for use. We can still access them as a part of clinical trials or on compassionate grounds, especially for post-pubescent teenagers. So we've got these drugs now to choose from, and obviously you need a good MDT, which I'm sure you have at Southampton, to narrow down on those choices and take it forward. So these are essentially the drugs that you have at your disposal.
Thanks, Akshay. I'm going to ask you with my question to predict the future, if you can. Assuming that these JAK inhibitors do prove to be safe and effective, and I think we maybe have a little bit of a ways to go to prove that, do you see the sand shifting in terms of the treatment paradigm, the treatment algorithms for managing IBD? Do you think that the JAK inhibitors, given that they are oral equivalents, given the relative cost and effectiveness, they might move up the list of drugs used and certainly earlier in the order of drugs?
Yes, I think we've in pediatric IBD we've sort of gotten used to starting children on anti-TNFs, and we've got this very sort of rigid schedule around what we do and when we do it, and it's partly related to the drugs that we have had at our disposal. But looking at adult data and even preliminary pediatric data, because there is some data available from the pediatric side of things. There is a multinational study in which Porto Group participated. Some of our centers participated as well, wherein they looked at induction data for upadacitinib, which is a JAK inhibitor for ulcerative colitis. And they sort of, came up with very, very promising results. And the good thing about the JAK inhibitors is, A, they are oral, but B, they have a very rapid response. So, even the pivotal trials, they showed that the JAK inhibitors start working as early as 2 weeks. If you give me a drug which I use for 2 weeks and it can tell me that is the kid going to improve or not, anyone will jump on it. I mean, the efficacy, the rapidity of onset, they've got predictable pharmacokinetics as well. So unlike infliximab, where you give the drug and then you wonder whether, you've given enough or whether you want to give more, it's one dose suits all over here in terms of induction at least. And then, there is no immunogenicity. So you don't need a support drug. You don't need an azathioprine or you don't need a methotrexate. So there are plenty of benefits here. Obviously, from adult studies, and again, from the induction study, which was like a multicentric study in the pediatric world, there are sort of concerns around the safety profile. And it basically stems from, the inhibitory pathways that the JAK inhibitors follow. So some of the common side effects, which have been seen previously and which have also been observed, include things like nasopharyngitis, or, you can have some transient hepatic enzyme elevation. There's also acne, which is very, very concerning for the pediatric age group. You get severe cases, with acne coming up and all of those things. There's a risk of herpes zoster, especially. And we've seen it as a part of, our trials that we were having, that, upadacitinib, it does give rise to, these sort of side effects. But I think the most concerning side effects, and, it is really, really important to make that distinction here. The serious side effects which people worry about were seen in the over 65s. So the risk of thromboembolism, the risk of major cardiovascular events, the risk of malignancies have essentially been seen, in the older age group. And again, that data is extrapolated from rheumatoid arthritis. So as we sort of sit down today, we are obviously awaiting robust data from our clinical trials. But suffice it to say that, I think, in my view, the side effect profile is a bit overplayed. I think for our patient population, those sort of concerning side effects have not been seen yet. But, as the data grows and we continue to monitor, we'll know more. But I'm sort of confident that over time, once we run out of our first line biologics, this would become a good second line agent to go to if children want to take an oral drug.
Especially in places where it's difficult to get kids in for infusions, thinking across the world. Yeah. And you touched on it there, but what are the ongoing clinical trials for these JAK inhibitors, thinking specifically about pediatrics? Because we've talked about the adult data and extrapolating that. Is there anything cooking at the moment that may give us some answers in the next few years?
Yeah, Chris, thanks for that question. I think the first trial that came around with the JAK inhibitors for pediatrics was with upadacitinib. And there's a trial called the U-ASTOUND that I'm sure a lot of people know about. A lot of people on this call are already participating. So that's upadacitinib in ulcerative colitis. And I think it's nearing the end of its recruitment now. So it became quite popular. And I think they recruited more than they thought. So that went on well. There's another trial which is ongoing. I'm not sure a lot of centers are participating, but a few of the UK centers are in it. That's upadacitinib for Crohn's disease. It doesn't have a fancy name like the first one. I think they ran out of the names, but anyway. So that one's there as well. So that's recruiting moderate to severe Crohn's patients for upadacitinib. And then there's another JAK inhibitor by the name of filgotinib, which will now begin to recruit, I think, in maybe around November, December this year. Filgotinib is again another selective JAK1 inhibitor, already approved in adults for ulcerative colitis in UK, in the EU and Japan. So this one's going to be starting soon, recruiting children So these three are running at the moment, or maybe running, just very shortly.
Great. Looks like we may get some answers soon then, hopefully.
Yes, that's my hope as well.
Thanks so much for joining us, Akshay, and contributing to the masterclass. With your help, I think we've given the listeners a really comprehensive review of JAK inhibitors, and certainly a lot to think about and digest.
Thanks again, Tracy and Chris. Thank you.
Thank you very much, and take care. Dear listeners, that wraps up our JAK inhibitor adventure. I hope it wasn't exactly a cognitive explosion, and I trust no neurons were harmed in the making of this episode. Thanks for tuning in till the very end. Bye-bye and see you soon.